I would like to invite Dr. Anil Shukla sir, Senior Pediatrician, past IMA President, on the stage. Dr. D.K. Agrawal sir, Senior Cardiologist, Director, Saraswati Heart Care Center and Multi-Specialty Hospital. Dr. Vinay Pandey, Assistant Professor Cardiology, Motiara Medical College.
Good evening, everybody, and as we come to the fag end of this very exhaustive but excellent CME on cardiology today, it's my pleasure to introduce the speaker for this session, Dr. Z.S. Meharwal. Dr. Meharwal is currently the Executive Director and Head of Cardiovascular Surgery, Heart Transplantation and VAD Program at Fortis Escorts Heart Institute. He has more than 31 years of experience in cardiac surgery with over 30,000 surgeries to his credit. He is part of the founding team of doctors at Fortis Escorts Hospital. He has worked as consultant cardiac surgeon at prestigious King's College Hospital in London. He is a pioneer in many new cardiac operations in the country. He is a leading heart transplant at Fortis Escorts Hospital. He has been actively involved in teaching and training. He has been listed in LIMCA Book of Records for performing coronary artery bypass surgery on 94-year-old man who is the oldest person to undergo CABG in 2008. With this short introduction to a very illustrious career, I now invite Dr. Meharwal to give his long-awaited lecture. Dr. Meharwal.
Chairpersons, friends, very good evening to you all. I'm sure you must be tired by now after an exhaustive CME today, but I think I was quite impressed by the topics. I couldn't attend most of them, but I think I did listen to a couple of those. Very informative and very educative. Let me first thank the Allahabad Medical Association for inviting me for this very important conference. I'll be briefly talking about very common issues in our day-to-day practice, and that is the surgical management of valve disease. And what recently have been the advances, when I say recent, not necessarily 2 years or 4 years, but at least the last 10 years. What have been the advances in the surgical management of valve disease? As practitioners, all of you have, I'm sure, hundreds of patients who are suffering from various stages of valvular heart disease, both mitral and aortic, and you continue to treat them with medications. But then there is a stage when these patients need surgical treatment. Rheumatic heart disease still continues to be the commonest cause of both mitral and aortic valve disease in our country, even though rheumatic heart disease has practically vanished from the developed countries. Another important challenge for us is that atrial fibrillation is a very common occurrence in these patients who have advanced valvular heart disease, and this certainly has impact on the long-term management and choice of therapy for these patients. Coming to the surgical management of valvular heart disease, it was in 1952 when Dr. Hufnagel implanted the first mechanical valve in the descending aorta of a patient with aortic valve disease. But it was in 1960 when two friends, Dr. Albert Starr, who was practicing in Portland, Oregon at that time. I happened to spend some time at his center in 90s, in fact in early 90s. A very great thinker and innovator. Along with his friend who was an engineer, Edwards, designed this first mechanical valve. It was called the Starr-Edwards valve. It was a ball and cage valve. And he used this valve and implanted it for the first time in 1960. And this Starr-Edwards valve then became commercially available in 1964. And for the next few decades, this was implanted in hundreds and thousands of patients. Last year, saw one of my patients who had Starr-Edwards valve 23 years back. So this did help a lot of patients for a long period of time. And over the last few decades, a large number of these mechanical valves came in the market. Multiple companies developed them, and currently available valves are mostly by leaflet valve, though we have an Indian valve also, which is a single leaflet valve, the Sri Chitra valve. But we also realize that these valves, they do have major challenges because they need lifelong anticoagulation. And anticoagulation obviously is associated with significant challenges and complications, which includes bleeding, valve thrombosis, and thromboembolism. And the risk of anticoagulation obviously depends on multiple factors. Primarily, the two factors are the range of INR which is required in a particular valve, and two, age of the patient. As the age of the patient increases, the risk of bleeding increases, and obviously the range of INR required after valve implantation varies from valve to valve, and more importantly, whether it is mechanical or whether it is mitral valve, aortic valve, or double valve. The two developments which have occurred in this field is one, the self-monitoring or the home monitoring of the INR. So it has become convenient for the patient to monitor at home. I'll just briefly mention that later on. And also, there has been some innovation on developing the valves which need lesser anticoagulation, which basically means that the value of INR can be kept low and the risk of anticoagulation would be less, and Onex is one of those valves. But it was very clear that anticoagulation certainly has a lot of challenges, and considering those challenges and risks to the patient, the surgeons along with the industry people, they started thinking of the tissue valves. And a surgeon from France, Alain Carpenter, along with same company Edwards, developed the tissue valve, the porcine valve from the peak in 1970s, and then from the bovine pericardium in 1980s. So in 70s, the tissue valve started. The advantage of the valve being that the anticoagulation required for this valve is only for 3 months. After that, you can stop the anticoagulation, and obviously the patient is not having all the complications which are associated with anticoagulation. So basically, we have two choices when we decide about the valve implantation. One is the mechanical valve, one is the tissue valve, but of course we also have the homograft and the stainless valves. Those are the separate categories, but primarily we have to choose between the mechanical valve and the tissue valve. So how do we choose? There are various factors, but whether we choose a mechanical valve or we choose a tissue valve, they both are associated with its own challenges. The mechanical valve with the anticoagulation, and the tissue valve, they degenerate over a period of time. So it was very obvious to think that if you can repair the valve, it certainly would give better results as compared to the replacement. And the mitral valve repair then certainly became popular, and a lot of surgeons started extensively working on the mitral valve repair, developing various techniques. And today, a large number of patients with mitral regurgitation, particularly the degenerative mitral regurgitation, can be repaired. Unfortunately, the results of repair in the rheumatic population is not as good as in the degenerative mitral regurgitation. And there are various techniques which the surgeons have developed for the repair of the valve, both for the posterior leaflet and anterior leaflet. And the posterior leaflet, which is the commonest one, is very simple to repair. The commonest pathology being the prolapse of the P2 segment of the posterior leaflet, and any surgeon can do this repair. The anterior repair is a little more complex. Also, the frequency of successful repair is relatively less as compared to the posterior repair, and the long-term freedom from reoperation again is less as compared to the posterior repair. And as I mentioned, there are multiple techniques which we use for repair, and these are some of the techniques which are used for mitral repair. So over the years, there have been significant developments in the valve replacement, as I mentioned, both in the technique of surgery as well as in the designs of the valve. And these developments have been associated with improved outcome to the patient. So the technique, I think this is a scar which a lot of you must have seen with the patients. It's a standard scar for our standard open heart surgery through median sternotomy. So the commonest technique for a open heart surgery is median sternotomy, but this has its disadvantages. There's a long scar in the middle. Cosmetically, it doesn't look very good, and also the sternum does take a couple of months to heal. So obviously, it is associated with a certain drawback. And considering that the surgeons developed minimally invasive valve surgery, minimally invasive cardiac surgery in general, including the valve surgery, and the idea was to minimize pain to the patient, to give better cosmetic result with short hospital stay, a faster recovery, and less use of blood and blood products. We use many techniques for so-called minimally invasive valve surgery. The two commonest for the aortic valve is the small right mini thoracotomy through the second intercostal space. We can also do minimally invasive aortic valve replacement using upper partial sternotomy. Again, this will give a little better cosmetic result without cutting the full sternum. And for the mitral valve and the tricuspid valve, we use right thoracotomy through subcostal incision, which again becomes a little more important in females. So when it comes to the choice of valve, how do we decide whether we should use a mechanical valve and a tissue valve? If one has to look for an ideal valve, this valve should give a good hemodynamics to the patient. It should be quiet because these valves do produce some noise. It should not require anticoagulation. It should last for patient's life. It should be relatively cheap, and it should be easy to implant. Unfortunately, even today, this valve doesn't exist. And each of the currently available prosthetic valves, they have inherent limitations. So as I mentioned, both the mechanical valve as well as tissue valve, they have their own drawbacks, and we have to choose the mechanical valve or a tissue valve, looking into account the risk of anticoagulation, which is associated with the mechanical valve, versus the risk of structural degeneration, which required reoperation at certain point of time in future. The American College of Cardiology, American Heart Association, and the European College of Cardiology and European Society of Cardiothoracic Surgery, they develop the guidelines every few years as to what valve we should use. These are the latest guidelines, but important thing which I think you need to see is that if you look at the first one, it says that a shared decision-making process, looking at the patient's values and the preferences, and discussion of the risk of anticoagulation and the risk of reoperation in tissue valve should be is the class 1 recommendation, which basically means that you need to discuss with the patient very clearly what are the risks involved with the mechanical valve, what are the risks involved with the tissue valve before taking a decision. But in general, the age of the patient is the most important criteria when you decide between a mechanical and a tissue valve. And in an aortic valve, if the patient is less than 50 years of age, the mechanical valve is preferred. If the patient is more than 65 years of age, the tissue valve is preferred, and in between 50 and 65, it is, as I mentioned, after discussion with the patients, looking at patient characteristics and patient preferences. In the mitral valve, the age is 65, so before 65, the mechanical valve is preferred. Above 65, the tissue valve is preferred. There are certain specific situations where the tissue valve is used. For example, pregnancy is one of them because the anticoagulation is associated with certain risks to the mother and the child, and therefore, in a childbearing age, if the patient wants pregnancy, the tissue valve or a bioprosthesis is preferred over mechanical valve due to lower maternal and fetal risks. It's class 2A recommendation. As I mentioned, self-monitoring of INR is now possible. So the patient can buy this machine and can do the INR at home in a similar manner as the blood sugar, and it certainly makes the management of anticoagulation convenient for the patient. And there are studies to suggest that this home monitoring of INR actually is as good, and in fact in some studies it is better than the institutional management of INA. This is a meta-analysis of 11 studies enrolling more than 6,400 patients, where the results showed that there was a significant reduction in thromboembolic events in the patients who use self-monitoring as compared to the institutional monitoring of INR. There have been a lot of developments in the tissue valves over the last 10 years. Currently, these are the currently available tissue valves, primarily of two types: the porcine valves and the pericardial valves, and these are from different companies. So currently, we have third generation of tissue valves, which have evolved over the years, and the expected durability of these valves is much more as compared to the first generation and the second generation valve. These are the currently available third generation valves from different companies: the Inspiris Resilia, Magnais, Avalus, and Daffodil. The last two, the Percival and Intuiti, these are the switcherless valve. I'll briefly mention about these valves as well. The Inspiris Resilia is a third generation valve from bovine pericardium. I think I should mention at this point that the major focus of any company currently is on the anti-calcification management of these tissue treatment, because this valve fail by calcification of the pericardium. So the pericardium or the tissue valve, the calcium gets deposited, it degenerates the leaflets, and the valve degenerates, leading to regurgitation and stenosis, and that's why the patient needs reoperation. So the companies have focused a lot and done a lot of research on finding the anti-calcification measures, and these currently available valves are certainly is expected to last longer as compared to the previous valve. So this is one of the third generation valves, as I mentioned, which is expected to last longer because of the anti-calcification measures which has been used in the treatment of the valve. The second focus of all the companies is to produce valves which can be friendly for future valve-in-valve. As all of you know, the transcatheter valve implantation has become quite common now, and we have to be prepared that the patient may need a second procedure. So the patient has a surgical valve replacement, either it is mitral or aortic, and needs a second procedure. It can be a transcatheter procedure, provided the valve is suitable for that. So this valve has incorporated two features which makes it useful for potential valve-in-valve, and one of them is the fluoroscopically visible size markers, because at the time of the second implant you want to know what size the valve was implanted. And the second feature which has been implanted or which has been used in this valve is the expansion zone. So as you can see here, this expands. So at the time of second valve-in-valve, you can expand this zone, and a bigger size of the transcatheter valve can be implanted. This is another third generation valve, Epic Plus. Again, the focus being on two things: one, the anti-calcification treatment, making it more durable, and secondly, again, to make it friendly for future valve-in-valve. And as you can see here, there are radio-opaque markers, and these radio-opaque markers can be seen under fluoroscopy, and one can see the annulus in the stent post. So you exactly know the anatomy of the surgical valve, which was not possible in the first generation and the second generation valve. And so obviously doing a valve-in-valve transcatheter procedure in those valves was very challenging, but these will make it much easier and much simpler if the patient needs a future valve-in-valve. I had mentioned about the switcherless valve. They are also known as rapid deployment aortic valve. So these valves, see, normally when we do a valve replacement, we excise the valve, we take the sutures in the annulus, we pass those sutures through the valve and tie those sutures down to the annulus. These valves, they can be implanted without using the sutures, and that is why they are called sutureless valves. These are two currently available valves. One is the Percival from Sorin, the company's name is Corsim, and the second is Intuiti from Edwards. This valve is not available in India. In India, the valve which is available is the Percival valve. This is made of bovine pericardium mounted on nitinol stent. It's available for the last about 8 or 9 years, and we have been using it quite frequently. The major advantage of this valve is that because we don't have to use the sutures, the surgical time is less, and the cardiopulmonary bypass and the aortic cross clamp time is less. So certainly, in high-risk patients where the cardiopulmonary bypass time and the cross clamp time, which is basically the ischemia time for the heart, is important, these valves certainly give better outcomes. Because there is no sewing ring which occupies certain space, the effective orifice area. So effective orifice area is the area of the valve through which the blood will pass. So the effective orifice area of this valve is much larger, and therefore the hemodynamics is much better, and also it facilitates minimally invasive aortic valve replacement. And there are many publications looking at the hemodynamics of this valve, and the mean gradients across the valve of using this valve have been found to be much less as compared to the standard sutured valves. And also the effective orifice area has been found to be larger. We have been using these valves for many, since it became available. In fact, I was one of the first to use the sutureless valve in India. This is one of our very latest patients, where we did the coronary artery bypass grafting along with the sutureless valve. The coronary artery bypass grafting, as most of you must be knowing, we do on beating heart without cardiopulmonary bypass. So we did 2 arterial grafts, one the internal memory artery to the left anterior descending artery on a beating heart, and second, the radial artery to the occlus marginal artery on the beating heart. And so this is the left anterior descending artery which has opened. This is the internal memory artery, and this obviously on the beating heart. As you can see, the heart is beating, the lungs are being ventilated, and this is being anastomosed to the left anterior descending artery. Once you complete your coronary artery bypass grafting, the patient is put on cardiopulmonary bypass, and the aorta is cross-clamped, opened in a standard fashion, and you excise the valve like you would excise in a normal aortic valve replacement, and then you would use the sizes to decide which valve. So this is the valve, which is basically the Percival sutureless valve, and you just take 3 guiding sutures to implant this valve at the annulus, which takes only 5 minutes, in fact 4 to 5 minutes to implant this valve, unlike 30 to 35 minutes or 40 minutes in a standard valve. And then obviously you close it as normal. And finally, a new valve made of polymer is also being investigated. The company's name is Foldex. It is a US company, and the name of the valve is Foldex Tria valve. It is both mitral valve as well as the tissue valve. The valves are made of polymer. This polymer resists calcification and can withstand stresses and strains without failure, so it is expected to last longer without degeneration. And this polymer is supposed to be thrombo resistant, so it would not need anticoagulation lifelong, and therefore the anticoagulation can be used only for 3 months, and it does not degenerate. So this is expected to have both the advantages of the mechanical valve as well as the tissue valve. The clinical trial of both mitral and aortic have been done. We were also part of the clinical trial of this valve in Fortis Ascot Heart Institute. The mitral valve is expected to come in the market after 2 years. The aortic valve maybe a little later. And finally, you must have all heard about this lifelong approach to heart valve replacement, which basically means that at the initial treatment of these patients, patient may have a surgical valve replacement, but when this valve degenerates in future, one can use the valve-in-valve using transcatheter technique, because currently available valves or current valves are quite friendly for future valve-in-valves. So with that, I thank you all for your kind attention. Please feel free to have any questions if you have. We still have 3 minutes, so if somebody has any questions.
Meharwal, for such a simple and comprehensive and detailed information about the valves in the cardiac surgery. Lots of improvements have occurred, and we are more or wiser to use these valves in certain clinical situations. Thank you, Dr. Meharwal, for the nice presentation.
Part of the
Yeah, sorry. Actually, I think the organizer forgot to mention that the topic, initially they had decided for when to refer, which obviously is an important topic, but then finally it was decided that I'll be speaking on what is the latest in the valve therapy. But answering your question, I think this probably is the most important questions which we need to answer for physicians and the practicing cardiologist, because in every surgeon's practice, including mine, we see patients who come at a stage when a lot of times these patients will have a severe pulmonary hypertension and the left and the right ventricular dysfunction. In fact, very recently I saw a patient who had mitral stenosis and mitral regurgitation, who had mitral stenosis and mitral regurgitation with a PA pressures of 85 with a TAPS of 9, a severe RV dysfunction with severe tricuspid regurgitation. So obviously this patient comes in a very high risk category, and when you probably will still operate this patient, but you know the risk of the risk of surgery is going to be very high, and secondly, the long-term results are going to be poor. So there are pretty standard guidelines for when these patients should be referred. I had a few slides on the ACC/HA guidelines for when these patients should be referred, but obviously because the talk had changed, so I didn't include those slides. But I think we should basically, these guidelines take into account three things. One, the patient's symptoms. Two, the echo findings, and the echo findings primarily talk about the severity of the valve disease, and third, the impact of this valve disease on the LV function, the RV functions, and the pulmonary artery pressures. So based on these factors, obviously there are pretty standard guidelines, and the patient needs to be referred when these patients meet those criteria for valve surgery. I mean, obviously the time doesn't allow that, but I have these slides to show those.
Sir, I have to ask one question that practice. How frequently are you doing total artery bypass grafting?
Okay, so I think the total arterial revascularization, basically if you look at the term, means that you are using only the arteries, right? So if it is a single mammary artery to the LAD, it is total arterial revascularization. If you are using two mammary artery to any two coronary arteries, it is total arterial. If you are using grafting three coronary arteries using a combination of arteries, then it becomes total arterial. So total arterial basically means that you are using only the arteries. The arteries which we use is the left intermammary artery, the right intermammary artery, and the radial artery. If you look at my own practice, my first preference of the conduit is the left intermammary artery, which is the conduit of choice world over for all the surgeons. The second artery of choice varies from surgeon to surgeon based on multiple things. My second choice of artery is the radial artery. And the reason why my second choice of artery is the radial artery, because of two reasons. One, we probably have one of the largest experience of radial arteries, not only in India but in the world actually. At present, my experience of radial artery uses in the International Society of Minimally Invasive Cardiac Surgery almost 16 years back, using 4,000 radial arteries, and even today this is the largest experience of radial artery uses of any single institute. But secondly, the reason why it's my second choice, because currently there is plenty of data to suggest that in some studies the radial artery results actually are better than the right intermammary artery, and it has become the second choice of artery for a lot of surgeons. Now one has to use a combination of these two arteries. One can also use a third artery as either as a free graft, or there are various combinations which we can use. Finally, answering your question, what number of patients would be, I would say, not suitable, but actually what patients can have total arterial revascularization. If you look at the world figure, the STS data, it's about 10%. So we all talk about the total arterial revascularization. And the reason the number is so small, because one, there is no solid scientific data to suggest that the long-term results of these patients are better than the patients receiving 1 or 2 arterial grafts versus total arterial graft. But secondly, also the arteries, not every artery is suitable for an artery conduit. So you have to decide which artery you have to use based on the patient's condition, more importantly on the artery where you are going to graft. But in general, I would say are about 25% or 25 to 30% of patients will have total arterial. The 70% of patients will have 2 arterial grafts, with the third one being maybe the veins.
Okay, sir. Okay. Thank you, sir.
Thank you.
I would like to invite Kamal Singh sir to facilitate the speaker and the chairpersons.